Okay, so this is our outcome measures project. All 4 group members worked on finding the information, putting it all in a presentation, and recording over the slides. Our first test is the dynamic gait index. The purpose of the dynamic gait index is to measure an individual's ability to modify their balance while walking with the presence of external demands such as obstacles. It also assesses the likelihood of falls in the elderly. This test tests 8 different aspects of gait: gait on a level surface, change in gait speed, gait with horizontal head turns, gait with vertical head turns, gait and pivot turn, step over obstacles, step around obstacles, and stairs. The target population is older adults, those with multiple sclerosis, Parkinson's, who are recovering from a stroke, vestibular disorders, and who have a brain injury. The area of assessment is balance, functional mobility, and gait. The ICF domains is activity and participation, disability, and quality of life. The administration methods, so you're going to need a box or a shoebox, 2 cones, stairs, a 20-foot walkway that's 15 inches wide. Time will be about 10 to 15 minutes. There's no training required and no cost except the cost of the equipment that you need. The safety concerns is these people may have gait problems, so just make sure that you or someone else is close to them, so just in case they fall, you can catch them.
The dynamic gait index is scored on a 4-point scale that correlates with the 8 different aspects of gait. Each one is scored from 0, indicating the lowest level of function, to 3, indicating the highest level of function or normal. Overall, if the sum of the scores is less than 19, that is predictive of falls risk in community dwelling elderly. This will let you know that this is an area of their function that you would hope to improve with physical therapy. The following are the instructions written as if you were talking to the patient and explaining each phase of the test to them. So as you'll see, some of them can sound a bit confusing, so clear verbal instructions are going to be super important to help the patient score accurately on the test. You'll score them on that 0 to 3 scale that we just described by marking the lowest category that applies to them at each phase. So phase 1, you would tell the patient, walk at your normal speed from here to the next mark, and you'll have a marker placed 20 feet away from their starting position. Phase 2, begin walking at your normal pace. When I tell you go, walk as fast as you can. When I tell you slow, walk as slowly as you can. And you would change the speed that your patient's walking at every 5 feet. Number 3, this can be the confusing one for them. Begin walking at your normal pace. When I tell you look right, keep walking straight, but turn your head to the right. Keep looking to the right until I tell you look left. Then keep walking straight and turn your head to the left. Keep your head to the left until I tell you look straight, then keep walking straight but return your head to the center. Number 4 is kind of the same thing, a little bit confusing. Begin walking at your normal pace. When I tell you to look up, keep walking straight, but tip your head up. Keep looking up until I tell you look down, then keep walking straight and tip your head down. Keep your head down until I tell you look straight, then keep walking straight, but return your head to the center. For the second half of this test, you'll need to make sure that you've got the materials that we mentioned earlier. So you'll need a shoebox, 2 cones, and access to some stairs. For phase 5, tell the patient begin walking at your normal pace. When I tell you turn and stop, turn as quickly as you can to face the opposite direction and stop. For the 6th phase, you'll set up the shoebox before. Tell the patient begin walking at your normal speed. When you come to the shoebox, step over it, not around it, and keep walking. For the 7th phase, you'll set up 2 cones, 6 feet from the starting point and 6 feet away from each other. Tell the patient begin walking at your normal speed. When you come to the first cone, walk around it to the right side of it. When you come to the second cone, walk around it to the left. And then the 8th and last phase, you would tell the patient to walk upstairs as they would at home, using the railing if necessary. At the top, turn around and walk down. As you perform this test with the patient later on in their treatment, we would hope that their score would increase. But if it decreases, that means that They would have an increased likelihood of falls and a decrease in balance, functional mobility, and gait. The increase that we're looking for would indicate a decreased likelihood of falls because we would have seen increase in balance, functional mobility, and gait.
As far as reliability goes, when looking at a geriatric population in either an outpatient or hospital setting, the Dynamic Gait Index has excellent intra-rater and inter-rater reliability, meaning that no matter who conducts the test, the score should be very similar, if not the same, when evaluating the same patient. The Dynamic Gait Index also has excellent criterion validity when looking at the same geriatric population and when referenced with a Berg Balance Scale or the Balanced Self-Perceptions Test. However, its validity drops when referenced with either the assistive device history or the history of imbalances. The next test we're going to be looking at is the Shoulder Pain and Disability Index. The purpose of SPADI is to assess pain and disability in the shoulder and measure the degree to which the shoulder pathology affects them. SPADI is a self-report questionnaire with 13 different sections. 5 sections are for pain and 8 are for disability. Pain is assessed on a 0 to 10 scale, where 0 equals no pain and 10 equals the pain is unimaginable. Disability is also assessed on a 0 to 10 scale, where 0 equals no difficulty and 10 equals cannot do it, it requires help. This questionnaire will be given to patients with shoulder pain or a known pathology of the shoulder. With this questionnaire, you're assessing the activities of daily living patient functional mobility, and it is under the ICF domain of body structure and function. All you'll need to administer the test is the SPADI form and a pencil. It takes about 5 to 10 minutes to fill out, and it isn't going to cost anything. There are no real safety concerns, but one area of concern is that with it being self-reported, there is no guarantee that the patient will tell the truth, so that is something to keep in mind.
So now we're going to get into the kind of the administration, scoring, and how to interpret a SPADI score. So like we mentioned previously in the presentation, it's a self-report questionnaire where the patient will receive questions. Each question they get, they're answering on a 0 to 10 scale, 0 being the best and 10 being the worst. So they're going to get 5 questions that are related to their pain levels for a total of 50 points related to pain. And then they'll get 8 more questions that are kind of based on their functional level and their disability. And so those 8 questions will give them a total of 80 possible points. So when you get the questionnaire back, you're going to take the total of all of their answers and score it as a percentage of the 130 possible points total. And then how to interpret this: so the closer the score is to 0, so the lower the score is, the better the outcomes of pain level and functional abilities of the patient. And then the higher you get, closer to that 100% mark, is going to be the worst score. So that would indicate a higher pain level and a lower functional ability. So next we'll talk about how to interpret a change in SPADI score over time. So like we said earlier, the closer that score is to 0, the better, and the higher it is, or the closer the score is to 100, the worse. So over time, if you saw a decrease in a patient's score, that would be a good thing. It would show an improvement in the pain level, so a decrease in pain, and or an improved function or function level of the shoulder. On the other end of that, if you see an increase in SPADI score, that's going to tell you that there's either an increase in pain level and or a decrease in the function of the involved shoulder. So now I'll discuss some reliability and validity values that we found in the references that we use. When it came to test retest reliability, so that's the ability of this outcome measure to find a similar score in different repeated trials. It showed a test retest reliability between 0.64 and 0.66, which is, it's only considered an adequate reliability for test retest. Moving on to validity, we found that criterion validity for the SPADI test, when it's being compared to active range of motion as the reference standard, showed a moderate to a high correlation ranging from 0.55 to 0.8. Then moving on to construct validity, we found that there's a correlation of 0.54 to 0.8 with active range, and then a correlation of 0.61 with the health assessment questionnaire. And then we found that they were able to establish face validity with this test, and that was done by using a panel of experts that selected items that they thought related to disability and pain with shoulder problems. So on this last slide here, we have the reference